My name's David Putrino, and I am coming to you from New York, where I run a center called the Cohen Center for Recovery from Complex Chronic Illness, which we shorten down to the core because you've always got to have a good acronym for things. I am most definitely here out of complete selfishness because, as I was saying to Chesley, we get probably 200 to 300 emails a day from people outside of New York saying, can we come to your center? We're not supposed to be a destination center. We're not supposed to be a center that, caters to people who can, come in and pay all the money in the world. We take insurance. We don't accept cash pay. And what we try to do is find solutions for people in their state or where they are, in their cities, in their towns. So education is a big part of that. So I'm going to start this short presentation off because I want lots of conversation and I just really want to hear from you all rather than you guys listen to me drone on. But I'm going to start off very simple to really define what we're talking about. I'm going to get a little bit scary, hopefully not too scary, and then a little bit hopeful to indicate that maybe we've got some ideas that could move the field forward a bit. So let's start off simple. Let's start off with just working definitions. When we talk about infection-associated chronic conditions and illnesses, when we talk about long COVID, what are we talking about? And why should we be worried about these problems? So I like a really simple working definition of an infection-associated chronic condition or illness. These are disease states that emerge when somebody fails to return to their pre-infection health status after an infection. I also throw in or exposure event because we also know that this can happen after toxin exposure. This can happen after traumatic events. This can happen after brain injury. And we start to sort of see some commonalities in the way that the immune system behaves, in the way that persistent pathogens behave in these frameworks. So that's the simple working definition. If we build on that and we think about some of the guidelines that exist for diagnosing these conditions, let's take a look at the National Academy's clinical case definition of long COVID. As you'll see, it mirrors pretty closely to what I said. So sorry for all the words on this slide, but it's an infection-associated chronic illness. HHS added in another C into the acronym, but this was published before that. But look at the way it's being defined. It occurs after a SARS-CoV-2 infection, and if someone is experiencing symptoms for at least 3 months, in a way that could be continuous. So they've just been feeling terrible for 3 months since they got the virus. Relapsing, remitting. So they can feel good for a few weeks, but then crash again and feel good for a few weeks and then crash again. Or progressive. So they just have been on a downward spiral functionally since that COVID infection. But the point is you can link it back to a COVID infection. They were at one health status, they had a COVID infection, now 3 months later they're at another health status. The other thing to sort of think about here is that the National Academies also urge us to make diagnoses of long COVID, understanding that it can manifest in multiple different ways. So somebody can show up and say, listen, I had a COVID infection, I've just been fatigued ever since. A single symptom. I'm fatigued and I just can't seem to shake it. Or it can be multiple symptoms. So they could say, look, I'm very fatigued and I'm experiencing cognitive impairment and my sleep is disrupted. These aren't diagnosable conditions, but they're multiple symptoms and they have been around since the COVID infection and they're not letting up. Similarly, long COVID can manifest as single or multiple diagnosable conditions as well. So someone may present with POTS, postural orthostatic tachycardia syndrome, meaning that when they go from sitting down to standing up, their heart rate jacks up, 40, 50 beats per minute, their blood pressure changes, they feel dizzy, they feel like maybe they're going to pass out. A provider can diagnose them with POTS, but they can diagnose them with POTS secondary to long COVID because it was the COVID that triggered the POTS. So again, I know that this is getting into the weeds a little bit, but this is how the diagnostic criteria go. And many of our other infection-associated complex chronic illnesses follow this same framework. Link it back to that triggering event. And if you were at one health status and then the triggering event happened, whether it be a tick bite, whether it be an enterovirus infection, Epstein-Barr virus infection, if you can link it back to that initial triggering event, then you can diagnose someone with one of these infection-associated complex chronic illnesses. I also just want to point out that both the CDC and the National Academies really drives home this idea that you don't need a biomarker to diagnose these illnesses. Your patient is your biomarker. You should not be required, we actually do have these arguments sometimes with insurers. Oh, well, show us the biomarker, the blood test that says that they have long COVID. Well, that's actually not how you diagnose long COVID. That's not how the CDC says that you diagnose long COVID. It's not how the National Academy says that you diagnose long COVID. It is a clinical diagnosis based on symptom presentation and following the guidelines that are published. So that's how we're thinking about long COVID as an entity, a diagnosable entity. Why should we be worried about this? So the first reason I'm worried is that last year the NIH Recover group published a study basically telling us that diagnosis rates of new long COVID cases have not changed between 2020 and 2024. There has been a sort of a conventional narrative of like, oh, COVID's over and long COVID isn't really a thing anymore. Yeah, there's the sort of OG cases of long COVID was stuck around, but like, it's not a problem. The data vehemently disagrees with this. And for the record, in this study, this was not, they did not count a new case of long COVID as someone who's been sick for 4 years and finally got their diagnosis. These were new cases of long COVID from recent infections. So it really tells us that long COVID is still with us and it's kind of happening in similar rates as it was happening back in 2020. So I'm worried. We should also be worried because it's an expensive illness. The median age of people who come to our clinic tend to be 39 years of age. So this is not an illness that is affecting elderly individuals, who are maybe at retirement age, and so it's not affecting the workforce. It is affecting individuals in the prime of their life, as well as affecting elderly individuals, as well as affecting kids. It's affecting everyone across the board, which is troubling. David Cutler from Harvard, who's a health economist, published in JAMA that this is a $2.6 trillion problem for America alone, based on loss of productivity, missing work, and the general overall burden that long COVID places on a household, including spouse and partners needing to caregive for sick individuals. So this is an expensive problem that is really taking away from our workforce in the prime of their life. And that's something that we see in the clinic every single day. These are folks who were previously high-powered professionals, high net worth individuals, extremely successful and driven individuals, and now they're taken out of the economy. It's affecting everybody equally, but these are the things that we see. And then probably the scariest for me and for everyone that I think about is we also know that just every COVID infection that you sustain, regardless of if you get diagnosed with long COVID or not, is doing some damage. So this paper in the New England Journal of Medicine is probably my scariest paper that I'm going to share with you today. It effectively showed in a large 150,000 person cohort that when they tracked people and controlled for the number of COVID infections that they had, and they separated out individuals who had been diagnosed with long COVID. So these were individuals who had no long COVID. These were individuals who said, I've had COVID, no big deal, I was fine. What they showed was at a median, you lose 3 IQ points for every COVID infection that you sustain and survive. So based on the sort of neuroinflammatory changes that COVID is causing in your brain, even with a mild infection, it's causing neurological damage that adds up and is cumulative. So this is why we should all be thinking about this as a problem that needs to be solved, because even if we're not feeling as though we actively have long COVID, we're still experiencing damage from this virus, which is not like other viruses. I think that this needs to be said often, that we're not dealing with just the flu. This is a novel virus, and it's having novel effects on our nervous system. So, because I haven't scared you enough, we're going to dig deeper into pathobiology of long COVID and discuss. One of the things that we've been doing out of Mount Sinai is we've really been trying to focus less on the myriad of symptoms that long COVID comes with, and zero in on what are some of the things that might be driving symptoms in long COVID. So what are some of the things that, if someone says that they have fatigue, yes, we're going to log that. We're going to say, okay, you have fatigue, and we're going to measure how bad your fatigue is using a scale like the fatigue severity scale. But then we want to know, okay, well, what's driving that fatigue? Like, do you have fatigue because you have autonomic nervous system dysfunction and POTS? Or do you have fatigue because you have neuroinflammation? Do you have fatigue because you have viral persistence? These are some of the things that we need to know if we're going to treat that fatigue. So in our research approaches, we're really trying to work very, very hard to really dig into understanding these drivers. Now, I've got 10 up here on the board, where these are 10 drivers that we've really validated with heavy-duty research, lots of publications in the field that really make it pretty clear that these are at play. There are other drivers that we're also looking at as well. So one, if you are someone who's quite long COVID informed, one thing that you may notice is missing here is hypermobility spectrum disorders, folks with joint hypermobility. We see this a lot in long COVID, where it's probably going to be the next driver that we add. And we are seeing absolutely in the literature emerging a link between people with long COVID and other infection-associated chronic conditions and illnesses, and the tendency to have hypermobile joints, which can then become symptomatic, can drive joint pain, can drive neurological symptoms, et cetera, et cetera. In fact, just a few months ago, a researcher at MIT, Mickey Tal, who studies chronic Lyme disease, published some work showing that when she infects animals with Borrelia, which is the bacteria that causes Lyme disease, over time, as the infection goes from acute to chronic, the Borrelia bacteria actually burrows into the collagen of the mice, and the mice become hypermobile. So there is a very clear sort of relationship between how persistent pathogens may be causing joint hypermobility. And then there are other mechanisms for it as well, just the chronic inflammation that can be caused by these illnesses, or the histamine release from the mast cell activation syndrome. These are all ways that that hypermobility can sort of enter the chat and cause some problems. So as we think about these drivers, I just want to share some evidence, to really point you toward how we think about these drivers and how they're on our radar. So for instance, when we think about SARS-CoV-2 persistence, even from very, very early on, this was probably one of the first papers from Zollner was the lead author on this, where they showed that up to 7 months after index COVID infection, folks with long COVID were showing persistence of SARS-CoV-2 antigen in their gut compared with healthy controls who had, well, convalescent controls who had survived a SARS-CoV-2 infection without, without any consequences, they did not have this sort of persistent antigen in their gut. Since this paper, there have been literally hundreds of papers showing similar evidence of persistence in other tissues, in other immune privileged sites, even in plasma. Work from David Walt's group at Harvard has shown that folks with long COVID are much more likely than healthy controls to have circulating spike protein in their plasma. So we're seeing that antigen persistence is probably a huge issue in a subset, at least, of folks with long COVID. What we're also seeing, unfortunately, is that the persistence of this antigen in the body is pro-inflammatory and oncogenic. So what that means is it is promoting processes in the body that keep promoting inflammatory behaviors and can even promote what we call oncogenic behaviors, which increase your risk of cancer. So this is work that is ongoing, but it shows us that there is an urgent need to address SARS-CoV-2 persistence, which, for the record, is something that has been denied for quite some time. From the outset of COVID, people were saying it's not a virus that can persist. It wasn't until 2024 when the NIH director finally said on the record, actually, we think that this is a virus that can persist, very, very quietly. And now we see it as self-evident. In addition to the SARS-CoV-2 virus persisting, there's also just been a huge body of evidence. This is a figure taken from a review article that was published in Current Virology in 2025, showing that SARS-CoV-2 is just, a virus that seems to have a penchant for reactivating herpes viruses. And so if you have latent herpes viruses in your body and you take a SARS-CoV-2 infection, you're going to have these herpes virus reactivations, EBV, herpes zoster, varicella, etc. And so this is important because what it tells us is sometimes the symptoms that people are experiencing may not be because of persistence, may not be because of some sort of primary POTS related to neuroinflammation, but it could actually just be that we've reactivated some latent pathogens, and what we need to do is target those pathogens rather than persistent SARS-CoV-2. All of this pointing toward our treatment approach is always test as widely as we can, find the drivers that we think are the problem, and treat those drivers. And then finally, I just want to talk about how SARS-CoV-2 can just cause neuroinflammation all on its own. And this was a study that we did with Michelle Mongi's team at Stanford, where we infected mice with a very mild form of SARS-CoV-2, where the virus did not leave their lungs, and they had a very mild illness course. And what we saw was that even with that very mild illness course, the animals started producing inflammatory chemicals called cytokines and chemokines that attacked white matter in their brain and caused brain damage even in that short period of time. And interestingly enough, the cytokines and chemokines that were causing the most white matter damage in the mice were found to be the same that we found to be overexpressing in people with long COVID that we were studying who had the most severe cognitive symptoms, indicating that even without persistence, even without any other mechanism at play, just the initial presence of the virus sets off this inflammatory chain reaction that can cause neuroinflammation and nervous system damage. I said finally, I've got one more scary slide, sorry. The other thing that we need to talk about is autoimmunity. So we're starting to see that a subset of long COVID patients are producing things that we call functional autoantibodies. These are antibodies that attack the body's own tissues. and they go on to cause tissue damage and symptoms. And in this work that we did with Akiko Iwasaki's team at Yale, this is still under review right now, so it's not yet published, but you'll see that the findings are quite self-evident. What we did here was we took antibodies from people with long COVID, from healthy controls. These were people who were confirmed to have never had COVID at the time of their blood draw, and from people who were convalescent controls, people who had sustained a COVID infection, survived, had no further issue. And we extracted IgG, which is an antibody from these people, and we went on to inject that IgG into mice. What we started to see was, as we this is called passively transferring the antibodies into the mice started to exhibit increased sensitivity to thermal stimuli. This is a proxy that we use for pain in people. So the mice started to be significantly more sensitive to thermal inputs if they received IgG from the people with long COVID, but not if they received IgG from the healthy controls. And the most interesting of all, and this is, I apologize for the busy figure here, but what we actually saw was that only the long COVID patients that had new onset pain as a result of their long COVID created this effect in the mice. So not only were we passively transferring symptoms, but we were passively transferring the same symptom into the mouse. So this really shows us that autoimmunity could be a driver, and as you can see, it's not all the long COVID patients, it's a subset of the long COVID patients. So it shows us that we need to subset out these patients, and these are the patients we need to treat with a specific drug for autoimmunity. So one of the things that we're interested in right now is FcRn inhibitors, which are a class of drugs that we use for, that are used for autoimmunity, that we think would be particularly helpful in this one cohort of long COVID patients. And just to tie it all together, I've mentioned 10 drivers. I've talked about some of the physiology that we've been seeing with our own eyes. But we also need to understand that this is a complex interplay. We need to understand that someone's hormonal health is constantly changing, and that can change their inflammation, that can change their functional autoantibodies, that can change a lot of the things that we're seeing here. We need to understand that people will have different stresses day to day. That's going to change their symptoms. So this is what we call a dynamic disability. And I think that all of these factors can sometimes be playing together in the same sandbox, and we need to understand that what we see one day will not be what we see the next day, and we need to be able to adjust to that with our understanding of the physiology. So I'll finish up with what to do about it. What do we need to do? What's the action plan? The first is we need more research. We need more research funding, but we also need to fund the right research. I think early on we got a little bit too jammed up with asking questions of people with long COVID and getting them to fill out surveys and really sort of not really just going after drug targets and treatments. And I also think that a lot of clinical trials were done without really digging into the mechanisms of why a drug might work in a particular patient. So, and what I mean by that is what we often did was, what was often done in a lot of long COVID clinical trials early on was, here's a drug, everyone has the same diagnosis, long COVID, so everyone's going to get the same drug. And we're not really going to take any blood markers or anything like that because there are no blood markers for long COVID. So we'll just see what happens. And hopefully the signal is big enough that this drug works. And without capturing some of these mechanisms, what usually happens is I've got a friend who works in the long COVID space. He calls it the rule of thirds. About a third of people felt much better. About a third of people didn't do anything at all. about a third of people maybe actually felt worse taking this drug. What does that look like in a clinical trial? That looks like a zero effect. That means that, didn't work at all. So a lot of what we do in our clinic when we're running clinical trials is we do a lot of exploratory responder analysis. We start to try and understand, okay, what is special about you that made this intervention work very convincingly on you in our clinical trial? And then what we can do is we can run larger clinical trials where we say, hey, for our inclusion criteria, we're only going to include people who have this biomarker up here or this biomarker down there, because in our exploratory analysis, that was what seemed to really move the needle. We also need to move fast on novel drug targets. Monoclonal antibodies are probably the most underutilized tool we have right now in terms of compounds that can effectively clear SARS-CoV-2 antigen that could be causing problems in people with persistent symptoms. And we're really not investigating them at all, because it took till 2024 for the NIH director to say, hey, maybe persistence is a problem. As a result, persistence strategies haven't been adequately explored. And in my opinion, we really need to start chasing some of these novel drug targets. I think that it is one of the most underutilized interventions that we could potentially have for folks with long COVID. We need a little bit of urgency around it. Novel device trials. I think that there are a lot of new devices coming onto the market that could be really helpful. This is a really weird looking image, I acknowledge, but this is actually a device that we just finished a triple-blind randomized controlled trial on, placebo-controlled trial on. The device is from a company called Pharion, and it uses something called microtesla magnetic therapy to reduce neuroinflammation in the brain. And in our cohort, what we actually saw was it significantly improved visual attention in people who got the active treatment versus the control placebo treatment. It improved processing speed, it improved attention and inhibition, and it improved just general emotional well-being. So it was a really exciting clinical trial. We're moving into a multi-site pivotal trial with this device now. As far as in all the clinical trials I've done so far, this has been the most promising that I've seen in moving cognitive outcomes in people with long COVID, which, as I'm sure most of us who work in this space will attest, cognitive symptoms are often the hardest to move. So it's something that gives me a lot of hope, and that's why I wanted to share it after all of my doom and gloom slides. We also should be doing novel drug combination trials. We actually just published this work, which was case series work, meaning it wasn't a randomized controlled trial, but it was a large cohort of individuals who took combination antivirals that were specifically selected to target reactivated herpes viruses and persistent SARS-CoV-2. So the drugs that were used were valacyclovir, Celebrex, and Paxlovid. And we saw a very, very strong response in people with long COVID that was durable out to 720 days of follow-up. So it wasn't just, hey, I feel a little bit better, and then 6 months later they were back to baseline. There was a really long, 720 days of follow-up, so 2 years of follow-up was really quite impressive there. So really what I'm trying to get at here is the fact that when we're trying to address persistence or reactivation of pathogens that have been with us for quite some time, we need new strategies, and often we need combination strategies. This is something that we've seen in the HIV world, and when we're thinking about persistent pathogens, and I think it's something that we need to adopt here as we're dealing with sort of these chronic pathogenic issues. And so finally, I'll just say we have a lot of content that is freely downloadable, and this is basically a how-to guide of how we run our clinic the assessments that we use, the billing codes that we use, really goes down into the nitty-gritty, probably into too much detail. It's 165 pages, but it's a resource for anyone who wants it. It's completely free. We're trying to update it every 6 months because our practice changes probably every couple of months right now as we're drinking from the fire hose and learning, but hopefully that's useful to you all. And then just wanted to thank everyone who actually did the work as opposed to me who's talking about the work. And yeah, any questions?
What were your doses on the last trial you talked about, the valproate and Celebrex?
Yeah, so it's 1,500 milligrams BID, so twice a day of the valproate, 200 milligrams twice a day of the Celebrex. That is done for 2 weeks before you then do 2 weeks of Paxlovid, at which time the dosage of the valproate goes down to 750 milligrams BID. This is all in the paper, by the way. And then once the Paxlovid course is over, you go back up to the original doses, and you continue that for a total period of 120 days. The protocol was developed by a physician by the name of Skip Pridgeon, who is down in Alabama, and he first started using just the valproate and Celebrex combo for his fibromyalgia patients. And he's a general surgeon, by the way, so he's just a curious guy, and a lot of folks were sending him chronic pain patients because he's a general surgeon, and he was like, why are you sending me fibromyalgia patients? I'm not gonna do surgery on them. But he tested their blood and he noticed that they had a lot of herpes virus reactivation, and he was like, well, this combo, the Celebrex, the Valtrex, Celebrex, we usually think about it as a non-steroidal anti-inflammatory drug, but what Skip points out is there's actually a lot of studies showing that because of the COX receptor that it blocks, it actually blocks herpes viruses from entering the cell, which then makes the valproate more effective at eradicating the herpes viruses. So that is his reason for combining the two, and it seems to work very effectively. So it worked well in fibromyalgia. It worked okay in long COVID, and then when he added the Paxlovid, which was this study we described, the folks who had the triple therapy versus the double therapy did much, much better. Yeah.
Can you share anything about, I know there's a trial with tirzepatide for treatment on COVID?
Yeah. The mechanism of action that has been proposed there is that it is basically reducing neuroinflammation at low dose, and it is reducing neuroinflammation by stimulating. When people talk about this stuff, I kind of chuckle because I call it jazz hands neuroplasticity. They're sort of like something magical happens and something in the brainstem stops causing a neuroinflammatory process, and then people feel better. And I'm not actually mocking the mechanism. It's probably a good mechanism. I'm mocking the fact that we know nothing about how the brainstem works, really. But yeah, so Scripps is running that trial, and it's fully decentralized. They expect it to be complete pretty quickly. We're watching it with interest. It's a really interesting trial. I'm curious as to how long people can persist with the drug. I'm also curious about what happens if your brainstem inflammation is occurring because you have a persistent pathogen that is irritating, the nerves. So like, are you going to feel fine, but if you go off it, you're going to feel terrible again? These are the sorts of questions that I think we need to answer, but I think it's a really, it's solid work that's based on a solid foundation, and let's see what happens.
So you noted earlier with the persistent infections, 3 IQ points, et cetera. Speak to us about the role of vaccination in moderating anything. So obviously vaccination can influence whether you get infected. We've seen that over time, but is there effects? Is there a difference? What are those who push for vaccination, et cetera? What's the message here relative to that?
Yeah, it's a great question. Right now, so the one thing I'll tag you on is, to date, all we have is evidence that vaccination reduces severity of acute infection, which is super important and therefore very, 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 very helpful in preventing mortality and morbidity in folks who end up in the ICU. We don't have data to suggest that it stops infection. And that presents a problem for long COVID, because what we've actually seen is that the latest literature shows us that vaccination does not alter your chances of developing long COVID. There was an early paper, Ziad Al-Ali's work from the VA, talked about a lower risk of long COVID with vaccination. Ziad walked that very respectfully and with lots of integrity, walked that back and said, what that was because the VA population tends older, what he was seeing was an epiphenomenon, so the vaccine was stopping a lot of these older folks ending up in the ICU, which then meant that they didn't get a long COVID diagnosis because of post-ICU syndrome and other sequelae related to being very, very sick acutely, which is a different beast, in my opinion, to a 35-year-old who has a few sniffles and then goes on to develop very debilitating long COVID. And so Ziad thought that was the sort of the thing that changed his data around. And so right now, the most of the literature confirms that vaccination is not really changing the landscape of long COVID risk, unfortunately. I'm also feeling pretty bullish for this reason on monoclonals. The drug that I'm watching most closely is Invivyd. They have VYD2311, which is their new monoclonal, which is broad spectrum. They are looking to label it as post-exposure prophylaxis. So basically, that you get exposed to COVID, you get a shot of VYD2311, it neutralizes the antigen. And their early data is I want some, their early data is really compelling that if you get a shot in your arm a day after, you're not going to get COVID. And so so I don't think it's hopeless. I think that there's a lot of things that we can do, but I'm more team monoclonal on that front for preventing long COVID than I am team vaccine. Vaccines are still extremely important for preventing severe acute infection, but I'm really looking toward monoclonals right now.
Any other questions?
Is there any other antiviral therapy that you're aware of that's some other antiviral research that's going on? Different antivirals.
We're currently running a clinical trial. I hesitate to call them antivirals, but repurposed HIV drugs. So we're running a clinical trial on Truvada, which is an antiviral that targets EBV pretty aggressively, but also other herpes viruses. We're also running a clinical trial on Maraviroc, which isn't quite an antiviral, but near enough. It blocks receptors that would allow viruses into the cell. And there's also, I know that Michael Peluso's team in UCSF is doing some work with, again, not quite an antiviral, but Anktiva, which is an immunomodulator that basically boosts the immune system's defenses to viruses. And in a similar vein, we're running a clinical trial right now on low-dose rapamycin with a similar aim, which is how can we boost T-cell responses to pathogens in such a way that the body takes care of these reactivations itself. I'm completely blanking on the 3 antivirals used, but there was a case series that emerged, that came out just 5 days ago. And if you give me a minute, I'll find it before the end of the roundtable. But it was in individuals who were immunosuppressed due to cancer, who had been infected with COVID for like 200 days plus. And they were given a combination of 3 antivirals together, which eradicated the persistent SARS-CoV-2 inside of about 5 days. It was a really effective regimen. So I'll chase that down. I know where the paper is. I just can't remember the 3 drugs that they used because I'm fried. But but yeah.
A question about the halo, that treatment.
Yeah.
What is it? How does it work?
So it uses very low intensity magnetic fields. Similar, if you've ever heard of transcranial magnetic stimulation, it's about 1/1000th of the intensity of TMS. So it's very sub-threshold. And what it does is it induces something called mitohormesis. So it stresses the mitochondria in the neurons just enough that they start to trigger antioxidant pathways. And what they showed in animal models with brain injury was that when they did it in an animal model, it promoted healing of the brain injury and it promoted a significant reduction in neuroinflammation. So we ran the first in human trial not so long ago in long COVID patients, and we saw some really impressive cognitive effects. We're still running the proteomics to see if we could see pro-inflammatory pathways being suppressed, which is still coming, but it was a really exciting first trial.
Question from online.
Oh, yeah.
Is there evidence that COVID-19 or long COVID is a vascular disease?
Yes, I mean, there is, that's a great question. And we have actually now published 2 reviews on all of the evidence showing that SARS-CoV-2 has the ability to cause inflammation of the endothelium, so the insides of our blood vessels, and then also causes overproduction of fibrin, which is a protein associated with inflammation, which then causes red blood cells to sort of aggregate together in things that are being colloquially called microclots, but can cause all sorts of microvascular issues. So we know that there is a vascular component to COVID for sure.